So I just wanted to welcome everybody to this ongoing series of webinars that are based upon the concept of age-friendly healthcare systems. And what we're looking at this round of presentations is the geriatric syndromes. And so as the entry slide indicated for the title, that today we're going to be looking at frailty. And so we want to understand why it's called a clinical syndrome. It's not quite called a disease according to Medicare, it's a syndrome. And we want to look at what the clinical manifestations are so that when you see somebody, you can come up with a determination as to whether they're pre-frail or intermediate frail or frankly frail. And I'll just kind of give you the punchline at the beginning here, that once somebody reaches a frailty state, they start to enter that window of the difference between active life expectancy and absolute life expectancy, which is about a 2 to 3 year window to consider. And then also in this presentation, we want to look at the frailty adverse events and measures that we can take to try to prevent frailty. There is a movement afoot to actually reverse the aging process. And I was looking at one of my slide decks here earlier today to think about maybe with our group here that to present some anti-aging interventions. And I say that cautiously because the anti-aging movement has really gotten a very bad rap for some charlatan activities, but there is some scientific basis, including research in my own laboratory about the interventions that we can do to slow down the aging process. Okay, so next slide, please. So we want to look at the evidence as to what actually leads to frailty. And then we're going to talk about the assessments. And when you assess something, you have to have a management plan. And then we'll get into more of a global view of prevention of frailty syndrome. And then talk about the differences between frailty and failure to thrive. And then finally, the concept of when to implement palliative care for a frail older adult. And the next slide, please. So what I'd like you to do as part of an active learning exercise here is write your definition of frailty. I mean, you can do it in the chat box if you wish. That would be used by any clinician to be able to immediately say, yes, this is a frail adult. And what I'd like you to do is at least find 5 signs or symptoms in your definition, if at all possible. If you get 2 or 3, that'll be good too. So like I say, just in the chat box, if you want to type it in, if you're a brave soul. And I'll start it off by saying that in my definition, I would include fatigue, which also happens to be one of the long COVID syndromes or long COVID symptoms. But I would put fatigue. So if somebody else wants to put in another sign or symptom that you would use in your definition of frailty, that would be wonderful. So just give it a couple of minutes here for thought. Okay, thank you, Sheila, for weight loss. Failure, yes, so failure. Yeah, great. So ambulation issues, breathlessness or shortness of breath, low endurance, perfect. Okay, yeah, so exercise intolerance, these are all good. See if anybody else has any additional thoughts here. Weakness, yeah, perfect. So I think collectively through group learning here, we're coming up with a pretty robust definition of frailty. Oh boy, I like that one. Recurrent hospitalizations. Yeah, that's been my rule of thumb. You know, if you're in the hospital more than 2 times annually, that's an indicator of frailty. Okay, yeah, and so ADL assistance. So this is interesting. Loss of activity or interest in everyday activity. So mood changes. What about cognition? You know, so would you include psychomotor slowing or memory loss as part of the frailty syndrome? You know, certainly physical performance measures like slow walking. You know, and so another one that came up, easy bruisability, which is interesting, just in a sense of skin integrity and just a general decline in physical functionality. So we've got mention of mild cognitive impairment. Well, good. Fantastic, guys. You really have come up with a lot of the signs and symptoms that people have used and have tried to integrate into defining frailty. And there actually continues to be controversy about whether frailty should or should not include cognitive impairment. So all the big guns that study frailty across the country will always have these types of discussions, but we'll march forward. So with the next slide, please. So frailty can be considered an age-related syndrome. And basically, from a more global perspective, it's a decrease in resiliency or physiologic reserves. And so these individuals become more vulnerable to different kinds of stressors. And so we certainly have seen this with COVID, where 75% of all the COVID-related deaths are in people over the age of 65 or over the age of 75. And as we were indicating in our chat box here, there are multiple symptomatologies such as weakness and fatigue. And because of all of these, it lends itself to a lot of adverse events, including falls, traumatic brain injury, hospitalization, nursing home placement, and so forth. Next slide, please. So some of the core concepts are that the frail individuals are at risk for different kinds of stressors. So, during heat waves, here we are with the Alberta Clipper passing through the Dakotas. So cold exposure, stressors such as infection, and we mentioned COVID, trauma, whether it be falls or otherwise, as well as hospitalization, which in and of itself is a risk for iatrogenic disease. So as a result of all these stressors, you see individuals having prolonged recoveries, further functional impairment. And so that leads to additional dependency, isolation, and eventually to the individual's demise. Next slide, please. So if you look at the postoperative delirium in frail older adults, you can see that there's about a 5-fold increase in this orange block here, column graph that shows that delirium in the frail older adult is significantly greater than people who are non-frail or whether they be healthy or with chronic conditions, but not frail. So you can have multiple chronic conditions and not be frail. Next slide, please. And this is a little bit of a graphic modeling, if you will, of how this whole concept of with aging in itself, we get loss of homeostasis. And homeostasis is the ability to fight back stresses, to fight back, infections, to deal with heat and cold stress. And you can see that on the bottom line here would be age, and that with age, you can see this kind of orange curve showing a decline in the ability to handle stress. And the idea is that at a certain point, we don't know exactly when, it's probably different for every individual, is that you may hit this dotted line where you go from potentially reversible problems with physical and cognitive functionality to permanent disability. So in the first phase here, we want to, prior to any of this occurring, we want to try to prevent it. And things like nutrition, blood pressure control, and physical activity are the key elements towards preventing frailty. And we'll talk a little bit about that later. Next slide, please. So we don't always know the trajectory of each individual, but some of them may be more susceptible for a variety of reasons to a change in function. So we know, for example, just theoretically, that we have 100% functionality. So everybody's able to do all their ADLs and IADLs, and then they get hospitalized, whatever that stressor is. Let's say it's a hospitalization for post-fall or maybe heat stroke. And you can see that there's 3 basic categories. There's the individuals that have a loss of function temporarily, but then they get back and recover what their pre-hospitalization functionality may be. And then there's another individual who maybe takes a little bit longer to get their functionality back, but it happens. And then there's another group, which turns out to be quite a larger group, that has loss of function, and then they end up not regaining any function whatsoever. And there was a Japanese study that suggests that you've got a 3-month window post-hospitalization to affect recovery or not. And I just find that to be an interesting rule of thumb. Again, it was a Japanese study. I'm not sure if it applies to other populations, but it certainly gives us some guidelines, is that we have a rather short window. And if you think about it, the 3 months is pretty close to what Medicare provides for that 100-day benefit of rehab. So there seems to be some common government sense, I suppose, in understanding what the window is for post-hospitalization recovery. Next slide, please. So I really like this, well, not the slide, but the Dalhousie Medical School's pictorial representation of the progression of going from very fit to the left to severely frail to the right. And it kind of gives you the sense, based upon mobility changes, as to how people progress in different stages of frailty. And again, this is not uniform. There are people who, go through life. They may become 100 years old and they'll only get to this vulnerable stage. So this is not an absolute progression for everybody, but it does give you an indication of where they stand on the scale. And one of the questions becomes, if somebody is moderately or mildly frail, can you reverse that and go to the left and make them vulnerable or even fit? And the question is, what would it take to do that? And then, and a parallel question becomes, if you have somebody that's, at what point in this continuum are things irreversible? Right? It's very much like kwashiorkor syndrome, where these poor children in Africa that just become malnourished, their stomachs bloat, and there's no nutrition whatsoever that's going to reverse that process before they die. So too, there's a similar concept here with frailty, that there may be a point of no return, and that actually has not been crisply defined yet. And there is evidence that we can reverse frailty if we catch it early. So therefore, that's why we ask those questions. Would you recognize frailty or pre-frailty if you saw it in the clinical setting? So next slide, please. So we consider, for the most part, at this point in time, that the severe stage is irreversible. It's pre-morbid, and it just has a 1-year high mortality rate, and that's why we often prescribe palliative care in those instances. Whereas in the earlier phase, it's more likely to be responsive to treatments, either through nutrition, physical activity, social support, and maybe cognitive psychosocial, and psychosocial interventions. Next slide, please. So what we call primary frailty can occur through just regular garden variety aging processes. They always talk about, as we get older, the things that are hard get soft, and the things that are soft get hard. So, as our muscles get more stiffened and the bones become softer, they're more brittle and able to break. So that might be the concept that we can conceive of, primary frailty. And then the secondary frailty is that what occurs with multiple chronic conditions. And so the more chronic conditions you have, such as diabetes, heart failure, hypertension, cardiovascular disease, all those accumulate together to accelerate frailty. And then if you add a little bit of issues like alcohol excess, not necessarily abuse, but alcohol excess, may drive that frailty quotient a little more vigorously, or accelerate it. Same thing with smoking and other lifestyle issues. Sedentariness. So they call sedentariness as the new smoking public health problem. Next slide, please. So the question is, how do we identify physiologically vulnerable frail older adults before they become clinically manifest? So that's our challenge, and that's why we're asking these questions. How would you recognize somebody that's going down the pathway of frailty? Next slide, please. So again, I kind of alluded to this, that the number of chronic conditions predicts the susceptibility to frailty, and that multiple systems get dysregulated. So somebody that has, inflammatory osteoarthritis, hypertension, diabetes, those are already three that might be accelerants towards frailty. So again, the more multiple chronic conditions you have, the more important it is to address the risk for frailty. And I would just add that we know, for example, that if you have 5 or more chronic conditions, that 1 out of 4 of those individuals also have cognitive impairment. And so we can start to get the sense of, these multi-systems being adversely affected by several chronic conditions. Next slide, please. Excuse me, I've been giving talks all day today, so my throat is a little raspy, and I apologize for that. But in any event, the clinical manifestations, things that we want to look at for identifying even pre-frailty, are changes in strength. What is, I was astounded when I was a nursing medical home director to find that post-hospitalizations that most of the older adults couldn't even lift 5 pounds. Loss of strength is important. Balance, that's why we do the Sharp and Romberg, where we have 1 foot in front of the other, and if they can't maintain that balance, that's also going to be a potential indicator for future frailty. Psychomotor slowing, so they just not processing things or moving fast enough. That could be that slowness. So somebody had mentioned that is slow walking. Just slowness in information processing is also an indicator. Poor nutrition, low endurance, low physical activity, no mobility plan or sedentariness, and then plus or minus, as I mentioned earlier, the issue about cognitive problems. Next slide, please. So there are groups of researchers that have tried to conceptualize this, the cycle of, I call it a dog chasing its tail here, but basically you get all these different components occurring where you get chronic undernutrition that leads to what they call sarcopenia or muscle loss. You then lose insulin sensitivity, so you become pre-diabetic. You start losing bone mass, and some people call it osteosarcopenia, where you lose both bone and lean body mass. You get a decrease in your oxygenation capacity. You lose strength, and so it leads to impaired balances and falls. And then as you go to the left here, with the decreased walking speed, you become at higher risk for cognitive impairment, additional falls, hospitalization, and eventually death. Next slide, please. So there's a concept called intensive care unit frailty. So it's very similar to the age-related frailty, where you get chronic undernutrition leading to muscle mass loss. It then leads to a decreased metabolic rate. Sorry, I just have to clear my throat here for a second. All right, sorry. And then you get lower energy expenditure, and so the cycle keeps going on and on. Next slide, please. So if we consider frailty as a physiologic process, we have these 5 factors that can be considered as a criteria for frailty. The first one is unintentional weight loss greater than 10 pounds. The next one is the self-expressed exhaustion. If you ask these questions, was it an effort for you to do things? Or if somebody says, I can't get going, in the morning, that those would be evidence of exhaustion. So you check that off on the list. And then slowness. And so basically somebody that walks less than 0.6 meters per second. In this particular study, they used footage as a measurement. Low level of activity. So this is basically an individual who's sedentary for the most part, but they do have a activity scale that you can measure this for how many calories kcals you spend per week. And then finally, decreased grip strength. And I don't remember the exact values of the grip strength, but they have some nomograms for that, and the cutoffs are gender different. So I think there's a 100 kilogram difference between men and women. Next slide, please. So some of the early manifestations are the expression of weakness and slow walking speed. So walking speed is one of the reasons why we have that as the 6th vital sign in our geriatric clinic. And then also decreased physical activity. So these are all kinds of things that we want to gather either by directly asking the patient or by asking their spouse or caregiver or family member. You know, a lot of times we'll just get a little clue by saying, daughter comes in with mom and says, you know, she's just not getting around as much as she used to. You know, so maybe we need to evaluate for frailty. Okay, next slide, please. So as we think about the differential diagnosis, all these symptomatologies can be related with other conditions other than frailty, right? So we just can't say, oh, they're becoming frail or they're pre-frail. There might be issues with endocrine disorders such as hypo or overactive thyroid. There might be some chronic inflammation, either of what we call inflammaging, where individuals get increasing inflammatory markers rising with their age. There may be issues related to organ failure, such as chronic kidney disease progressing from stage 3 to stage 4. And accompanying with that with, let's say, elevated potassium, which causes further weakness or anemia, and so on and so forth. So we need to think about the alignment of different diseases that may be associated, for instance, like with weakness. So there might be medication-induced myopathies, right? So anywhere up to 10% of older adults on statins for hypercholesterolemia may experience some type of myositis or myopathy leading to weakness, or alternatively, they got started on amiodarone and they become hypothyroid as a consequence of it, and they develop muscle weakness. So again, we always have to be fairly sharp on these questions. Yeah, go ahead. Thank you, Gunjan. Next slide, please. So the concept is, again, if we look at this at basic physiological methodology here, we have the clinical presentation that we notice in terms of decreased physical activity, decreased ability to perform physical activities. These are all components of the frailty syndrome, and they lead to further physiologic dysregulation and some changes at the very basic cellular and organ level. Next slide, please. So some of the causes to what we call primary frailty is the first point there is what we call inflammaging. So that's related to the steady increase in the cytokine called interleukin-6, and also the inflammatory, non-specific, but inflammatory marker called C-reactive protein. You'll also see these rise in during COVID and post-COVID. In fact, both IL-6 and not so much C-reactive protein are associated and elevated with long-haul COVID syndrome. The frail older adult will have evidence of decreased immune function that may be represented by lower percentage of lymphocytes. They may be anemic. They have an elevated hemoglobin A1C, and then other blood tests such as dihydroepiandrosterone and insulin growth factor are going to be decreased, leading to that increased diabetes-like situation. And there's other measurements. Their autonomic nervous system goes haywire, as indicated by heart rate variability. And I have to share with you, I have an Apple Watch which measures heart rate variability, and my heart rate variability was much lower than I would have expected. And so as a consequence, I've been a little bit more attentive to my treadmill, and slowly but surely my heart rate variability is getting big. So again, sedentariness can really make a big difference. Next slide, please. Okay, I'm getting a poor signal on my internet, so hopefully everything will be okay. I'm gonna shut off my video here to try and improve the signal. Sorry, can you go back to the previous slide? So in terms of secondary frailty, we know that the frailty phenotype occurred with untreated HIV and AIDS. You can see Freddie Mercury here really became quite debilitated in his final years of his life. Other conditions such as heart failure can cause a wasting syndrome, as well as chronic infections like tuberculosis. And all these lead to generalized weakness and frailty. Next slide, please. So the question is, why would we even screen patients for frailty? And one is we want to identify the risk and hopefully prevent the progression. So we want to do the assessment and try to get an idea of engage their severity, so as we can prevent or even treat the frail syndrome. And if not, if it's untreatable, then to transition to palliative care. Next slide, please. So probably the best way to assess frailty is to use the Freed scale, which I showed here a little bit earlier, that talked about weakness, fatigability, and loss of grip strength, slowness, and slow gait speed. There's another from St. Louis University, that second test there called the Rapid Screening Frail Scale, and others. And the bottom one here, the walking speed or grip strength, are two clinic-based or physical performance measurements that also have a lot of, well, they just make sense. And so that's why I say we're using walking speed in our clinic. Okay, next slide, please. So the Frail scale, that's a mnemonic for fatigue, problems with resistance, problems with ambulation, illness, and weight loss. So you can see that, like the 5-point scale from the Freed scale, that if you have 3 or more of these checked off on your list, that they would be considered frail. If they have 1 or 2, then that's considered pre-frail, and those are the ones that you really want to focus on for reversibility. Next slide, please. So some of the strategies for managing frailty, certainly comprehensive geriatric assessment is a way to go. At least in North Dakota, and I believe in South Dakota, there's not a lot of geriatric assessment clinics. We have one in Fargo at Sanford South Point, where I perform comprehensive geriatric assessment, and we also have a falls prevention clinic. But again, beyond that, it's important to kind of have a checklist of areas that can be addressed, such as polypharmacy. Just remember that if somebody's on 5 or more medications, there's a 100% chance that they're having a drug-drug interaction. And part of that could be a conduit to frailty. I can't tell you how many people are on multiple SSRIs and have loose bowels and malabsorption syndromes because they're just on a bucket load of antidepressant medications that aren't doing them any good. The fall risk is important to measure. ADLs and IDLs, part of the functional status, and also assessing their mood, sleep pattern. Now they're finding or reporting that if you get less than 6.5 hours of sleep daily, that you're at high risk for Alzheimer's disease. And then looking at other metrics, for managing frailty. And so if you have a clinical program and you have a panel of patients that you're saying, well, how well are we impacting frailty? Part of that's going to be measured by a reduction in nursing home admissions, for example. Next slide. So we want to try to exclude secondary causes of frailty when faced with somebody that's either pre-frail or frail. So some examples are atrophic gastritis. So they might have, I've found somebody that had a B12 folate deficiency because of atrophic gastritis. And so those hypovitamintosis states, was one of the reasons why they were having they were in the pre-frail state. A lot of times unresolved grief, particularly during COVID here with loss of family members, can be an important consideration. And you want to basically target the key components for trying to reverse or stabilize frailty by addressing physical activity, strength training, and nutritional interventions, remembering that 1.2 to 1.5 grams of protein per kilogram is what's recommended for the older adult. And then also finally, the point of trying to minimize vulnerability through enhanced social support and as much as possible trying to avoid hospitalization. So sometimes these elective surgeries for an 85-year-old for a shoulder surgery just doesn't make sense. So that would be a way to prevent frailty, because assuredly if that person, that 80-some-year-old individual, went for shoulder surgery, they would have a high risk of not really gaining much benefit and being exposed to iatrogenic diseases, unsafe medications, and just having a trajectory downward. So again, trying to balance relative risks and minimizing the vulnerability is really important. Next slide, please. So in terms of further strategies for managing frailty, we can look at the ADL, IADL support. So certainly Meal on Wheels, sometimes assisted living, or having a home companion. I know in Chicago, for example, when I was doing my medical practice in geriatrics at University of Illinois, we had the little sisters and brothers of the elderly do home companionship. I've prescribed personal trainers for older adults. It's kind of a novel concept for them if they don't go to the gym or Choice Center here in Grand Forks. Yeah, prescribing personal trainers is sometimes a way to get social engagement. And then the other points is to look at just basically converting people from a disabled state to an enabled state. And it's a slow process, but it involves connecting with other individuals, community-based resources, and hopefully through some type of geriatric programming at the medical centers. Next slide, please. Now, we want to talk a little bit about frailty prevention. And again, this is to anticipate and avert these losses in physiologic reserves. So sedentariness is really the major cause of frailty. It's interesting, even at a biologic level, just sitting in a sedentary position causes, for young people, a contraction of their telomeres, which is the end parts of the chromosome that are the kind of the pacemakers of the aging process. So you can only imagine that with an older adult who's got already shortened telomeres, that if they become sedentary and immobile, that their basic cell mechanisms are starting to react to it and cause even further damage at the cell level. The other thing that you want to look at is be very, what I would say, mindful of, depressive symptoms. And so a lot of times these are associated with decreased physical activity. I always ask my patients, what do you do when you get up in the morning? And if I get kind of a blank stare or I don't know, I know that there's some issues that we need to talk about in terms of healthcare goals and even just life goals. Okay, next. In terms of pharmacologic treatment, it's they've looked at android or adrenergic hormone replacement therapy and DHEA and so forth, and none of those work. If anything, they make it worse. And so some of the future treatments that they're looking at are addressing bioenergetics. I've been very fascinated with this company called Elysium. I have no relationship to it, but if you get a chance to look at their website, they are I don't want to say peddling, but they're promoting a non-medication vitamin precursor supplement called nicotinamide ribose, and it's kind of expensive. You have to take one pill twice a day. It's $60 for a 1 month supply. And it's kind of like a ramped up vitamin B1 complex. And but it's been proven in research to be effective at least in animal models. But and the reason I'm saying this is that that's addressing the bioenergetics. We know that the nicotinamide, the NAD cycle with age declines substantially, and so the mitochondria within the cells, the energy producers, aren't able to really rev up the energy and the ATP that we need to get going. The other part of this, by the way, is resistance training helps build those bioenergetic modules, those mitochondria. And so by resistance training, you help increase aerobic capacity and help address the whole question of weakness and low endurance. The question of anti-inflammatories is being tested as a frailty preventer, and not that I have a lot of evidence for frailty prevention, but I prescribe or advocate regular use of turmeric at 2 to 3 grams daily, that would represent an anti-inflammatory approach. Again, I don't want to advocate non-evidence-based medicine, but again, theoretically, that would fit the description of taking something that's anti-inflammatory. And then finally, the concept of decreasing polypharmacy. And so with the reminder that when you have 5 or more medications, that you have 100% certainty of drug-drug interactions that could range anything from GI distress to sleep disorders to weakness. Next slide, please. It's important for frailty prevention to not allow naps for more than 30 minutes a day if you're going to take a nap, and maintaining physical activity. So if you're watching TV during the day or night, to stand up and sit down during the commercials. You need to do at least twice weekly resistance or strengthening exercises, and then also do some balance exercises such as either Tai Chi or yoga. Again, bottom line is trying to prevent immobility. Next slide, please. There's some interest in the Mediterranean diet. So there are studies that show that it does lower the frailty risk, at least in one study. Protein and micronutrient supplementation is always a good thought. And I have here warning: sarcopenia occurs in obesity. So just because somebody has a high BMI or is a robust looking individual, they can have very low muscle mass, and so they could be pre-frail by the definition. So looks can be deceiving, is I guess the important lesson here. And so the bottom point there is that in many studies, nutritional supplementation is only effective when added to some form of exercise. So again, it's a multifactorial intervention or prevention plan here. Next slide, please. All right, so I want to talk a little bit about frailty and failure to thrive syndrome. So failure to thrive is a historic diagnosis when there were severe symptoms with no apparent cause, and they just look like they have the dwindles, is another way we called it. And so there's still controversy. It's, some people think we should just get rid of the term because it really doesn't have a particular mechanism behind it. and it just has some bad connotations. But the point is that there may be some overlap between frailty and the failure to thrive syndrome, but the failure to thrive syndrome, you'll recognize that almost immediately. These people are typically highly bedbound, just a wisp. They have temporal lobe or temporal atrophy and skin thinning, which somebody had mentioned earlier. So that would all be related to more towards failure to thrive syndrome. Okay, next slide, please. So the transition to palliative care is something to consider. And again, if somebody has one of those frailty scores of 4 to 5, coupled with either a low cholesterol level or low albumin, those would be candidates for consideration for palliative care. And again, you can use those screening tools, either the Frail or the Freed index. Certainly somebody that has a gait speed of less than 0.4 meters per second would also fall in that category. Next slide, please. So I'd like to summarize, and then we can open up for questions, is that frailty is a clinical syndrome that is associated with changes in bioenergetics, and there are some clinical markers such as inflammatory markers associated with it. It leads to a system-wide degradation of physiologic responses that occur both at the cellular and even molecular levels. The frailty indices, such as the Freed index or the St. Louis Frail index, account for these 5 parameters of weakness, slowness, low physical activity, low energy, and weight loss. And in my experience, weight loss has been the least revealing, or not revealing, but just least likely to be part of these 5 factors. Okay, and I think, do we have another slide there? Yeah, so high risk of adverse clinical outcomes is associated with frailty, creating this spiral downwards of increasing fall rates and disability and dependency. And we can understand frailty as that second point there as a continuum of severity, as if you recall that Dalhousie pictorial essay of frailty is a good conceptualization of early frailty, mid or intermediate, and then severe frailty. And in terms of prevention, just as a reminder, probably the best prescription is not so much a walking mobility program, but rather a resistance training program, and then from there going on to the endurance and balance. And then the role of the Mediterranean diet is just generally good. There's some data that shows that even a pure vegetarian diet will improve, as long as it has enough protein in it, will vastly improve physical functionality as we age.